let's get started. Okay, so kind of you can see a tumor, right? It has all features of anaplasia. And now you may ask me, sir, what is this tumor? So by looking at this morphology, this is a hematoxylin and eosin stain slide. Okay, so this is a morphological what you see every day. This is a routine diagnosis slide. Okay, so what I can say is this is a tumor and it is a malignant tumor because it has all features of anaplasia, including some very brisk mitotic count. Okay, many mitotic figures are there, typical, atypical. So this is a malignancy. Now, if you ask me what subtype of malignancy, just by looking at the morphology, I cannot say that this is a carcinoma or sarcoma or lymphoma or melanoma, right? I cannot categorize the tumor. I can just tell you that it's a high-grade malignancy. And as you all know, for any treatment, the specific diagnosis is required, okay? Now, if you say carcinoma, surgical. If you say lymphoma, chemotherapy. So, treatment depends on the diagnosis. So, what is this IHC all about? We will see. Okay. Now, immunohistochemistry is used in undifferentiated tumor. Now, this is, you can say, a very pleomorphic undifferentiated tumor. So, if I try these 4 markers, now a cytokeratin for carcinoma, C for C. Okay. Carcinoma cytokeratin, LCA is leukocyte common antigen, that is for lymphoma. HMB45 is for melanoma. And vimentin is for mesenchymal tumors, that is mostly for sarcoma. Okay, so you remember cytokeratin, carcinoma for the MBBS students. Okay, LCA is for lymphoma, HMB45 is for melanoma. You may get a MCQ or you may get a short note, okay, on immunohistochemistry. And vimentin is for the purpose of mesenchymal tumor. Okay, now if I do and I say that melan-A is positive or HMB45 is positive, then what this tumor turns out to be? This turns out to be a melanoma. See how it has helped us. Morphologically, I was not sure which subtype. I did some marker and I chose melan-A because it is a more specific marker for melanoma, melan-A from melanoma. Okay, so melan-A and it has come positive. If I would have done HMB45, if HMB45 was positive, then also I would have called it a melanoma. Okay. Now, with that note, we will go to our learning objective. So first we will see what is IHC, what is the utility of IHC, the classification, how they are classified, and this can pretty well be a short note for the MD people or people preparing for MD. Then you can have the workflow, how we put this IHC into use. And then in the end, we will see utility of these different IHCs in various system-wise or tumor-wise. Okay. So what is immunohistochemistry? Now, immuno means antibody, histo means tissue, and chemistry means there is some reaction. So immunohistochemistry, antibody, tissue, and a reaction. So this is a method which uses antibody to identify specific proteins or antigens in various sections. Now, these proteins can be on the surface, they can be on the nucleus, they can be in the cytoplasm. Okay, we will come to that. And this procedure or this immunohistochemistry technique can be performed on any kind of tissue. Remember, for MCQ purpose, immunohistochemistry can be done on paraffin, which we routinely do. HNE we do on paraffin, as well as immunohistochemistry is done on formalin fixed paraffin embedded tissue. Okay, paraffin tissue, we can do them also on frozen section. Frozen means we just freeze the tissue in kind of -30 to -40 degree, solidify the tissue, take a section, and on that we can do this immunohistochemistry. Now you may ask, paraffin embedded is fine, but why we are using frozen? Frozen because certain tissues, like suppose you want to demonstrate an enzyme. Okay, a muscle enzyme. A muscle enzyme, once it is processed through paraffin or it undergoes tissue processing, what will happen? All the chemicals will act on this muscle tissue and the enzymatic activity will be gone. Okay, so what we do, we just freeze the tissue and then we take sections and do the IHC. That way we can demonstrate the enzymes, or when we do IHC for enzymes, we use frozen sections. And cell blocks. Now, what are cell blocks? Cell blocks are tissue that are collected during FNAC. Whenever we do a FNAC or fine needle aspiration cytology, we collect some material and process it as a small biopsy. And that tissue is called as cell block. Okay. Now, you are very clear. We can try it on paraffin. We can try it on frozen. And frozen, you have to remember mostly two important uses. One is in kidney, we do IF or direct immunofluorescence, and one is for muscle enzymes. Okay. The third is cell block, or on cytology material also we can do immunohistochemistry. Now in immunohistochemistry, I showed you a picture that was looking brown, right? Like this. Now this brown color is because of the chromogen. We use certain like substance which will be visible to our eye. Now this IHC, after the staining, we observe the slide under routine or compound microscope. Okay. And if we have to see it in the microscope, then it needs to have some color. And then only we can say it is positive or negative. Okay. So usually most IHCs will stain brown in color, and that is because of a chromogen called as DAB. Okay. Diaminobenzidine. Okay. Diaminobenzidine, DAB. So that is the chromogen which is responsible for brown color in IHC. In addition to that, you can also have some red colors like this. Okay, it all depends what color you are using. So this is the cheapest and easiest. So most of the IHCs will use this DAB, whereas like flag red and so many, even you can have a black color. So it all, the chromosome depends on what we are choosing. Now what antibodies we use? Antibodies can be monoclonal or polyclonal. Monoclonal means it is derived from one specific, it will act upon a specific type of antigen, whereas polyclonal means they are derived from multiple plasma cells, or they can act upon multiple antigens. Now if you see the difference, polyclonal means they will be more sensitive but less specific. They will pick up any antigen, but they will be less specific because they are polyclonal. Whereas what is the advantage with monoclonal? Monoclonal means they will act upon a specific substrate, the one that we intend to check or the one we intend to know. So it will act on that, but again, because it is monoclonal, so you can say sensitivity will be low. Sensitivity is low for monoclonal, specificity is more, whereas for polyclonal, sensitivity is more, specificity is less. Now how this is done? Staining can be done manually, or nowadays in most high volume centers where we are doing lot of staining, it can be done by automated IHC stainer. Okay, so you just can remember it can be done manually, it can be done by automated methods. The other important point is controls are to be used. Now you can ask me, what is a control? Now control is a kind of like tissue that we take in order to see whether our test is true positive or true negative. For example, now suppose I know a tissue that is having melanoma, okay? Or I have a tissue that is a melanoma tissue. Now I want to compare the same tissue with another tumor and both are stained with melanin. If the test takes up and the control takes up, that means it is a good one, okay? Because both have worked properly. But if your test doesn't take up and your control takes up, that means it is true negative. If both are positive, it is true positive, whereas if your test takes up and control doesn't take up, then we cannot interpret that result. But reverse, if your control is positive and test is negative, that means the test is true negative or that tumor is not a true melanoma. Okay, now these controls are different types. You need not go into that. It can be within the tissue, it can be on slide, it can be an extra outside slide. So those are different things. And as I've already told you, this is something that we visualize under the microscope. Okay. Now that was about little bit of antibodies. And what other tests? Now you may get a question like, what other test that uses antibodies in tissue diagnosis? The other thing is immunofluorescence. I've already told you, this is done on frozen tissue. Okay, immunofluorescence is done on frozen tissue, most commonly done for kidney biopsies and skin biopsies to see any deposits. It is also done in muscle tissue to demonstrate the enzymes, whether they are present or absent. Okay, and this we have to visualize under a special microscope that is called as immunofluorescent microscope. Remember, IHC we are seeing under a compound microscope, whereas immunofluorescence we are seeing under immunofluorescent microscope. We cannot see it under our normal microscope. Then comes the next one, that is immunophenotyping. Now people going for NEET will be very clear what is immunophenotyping. Immunophenotyping is a method by which we try to confirm and categorize leukemias. Okay, leukemias and lymphomas. And on one tissue this is done. This is done on bone marrow aspiration. BMA is bone marrow as well as peripheral blood. If the peripheral blood has enough abnormal cells, we can do this immunophenotyping on peripheral blood, but preferably for immunophenotyping, we need bone marrow aspiration material. Okay. Now this immunophenotyping here, we just like what we say IF and IHC, we cannot see it. What we see is the events that was occurred on the screen. So it will be something like that. Okay, so just you need to know this immunofluorescence as well as immunophenotyping. There are also certain methods where this same principle is used, that an antibody goes against and binds antigen and we detect it through some method. Now, what is the utility of IHC? Now, I told you I have shown an example where it helps you to diagnose and confirm. First of all, it will help you to diagnose. I am thinking whether it is a lymphoma, carcinoma, sarcoma, melanoma, it will help me to confirm. Okay, like I said, if cytoplasm, you have cytokeratin is positive in the cytoplasm, you can say it is a carcinoma. Now categorize. I have told you again, categorize the type of tumor. First of all, we know that it is a tumor. Now, for example, say breast carcinoma. Breast can have different type of carcinoma. Say a lobular carcinoma, it can have ductal carcinoma, and different tumor will have different prognosis. So that is called as categorization. Okay, first we have confirmed that there is a carcinoma, and then now we have to say whether it is lobular versus ductal carcinoma. For that, we use a stain that is called as E-cadherin. So if E-cadherin is positive, it is ductal. If E-cadherin is negative, it becomes a lobular carcinoma. Then you can also talk about patient's prognosis. There are certain markers like say Ki67. Now we know that Ki67 is a proliferative marker, or it tells us about how rapidly the tumor cells are multiplying. The higher the Ki, the faster the tumor is multiplying. Okay, so a tumor that is having a very high Ki67 will have a good prognosis or bad prognosis? Come on, it will have a bad prognosis because it is rapidly growing. Okay, so that is how it tells us prognosis. In addition to that, also there are certain markers like ER, PR. Now even the MBBS students will know that we do certain markers on breast biopsy, that is ER, PR, HER2/neu. Okay. Now, ER and PR, you must specifically remember, ER, PR and KI are actually your prognostic markers, okay? Because your therapy depends on it. And if ER is positive, patient will have a better prognosis. Now, the fourth category is prediction of therapeutic response. Now, again, I will give you the same example. Like suppose ER is positive, we can give estrogen therapy, okay? Or estrogen receptor therapy. If your Herceptin is positive or HER2 is positive, then we can give Herceptin. Okay, so you see ER is a prognostic marker, whereas HER2/neu is a prediction of therapeutic marker. If HER2 is positive, that means Herceptin can be given. If HER2 is negative, Herceptin drug cannot be given. That is how it helps us. So it helps us to diagnose, it helps us to categorize, it helps us to decide prognosis, as well as helps in prediction of therapeutic marker. Now remember, what I am giving you is just simple example, simplified version, but in real life it is not that simple. I am giving you just one example. There are multiple utility of IHC. Now how they are classified? Based on usage. Diagnostic, I have already told you, CK and LC. Now if I have a tumor, if LC is positive, it's lymphoma. If CK is positive, it's a carcinoma. Prognostic markers I have explained. Therapeutic markers I have already told. If HER2 is positive in breast carcinoma, we can give Herceptin. Similarly, if CD117 is positive, then imatinib therapy can be tried. The CD117 is positive in certain tumors, where if this is present, then certain therapy can be given. So that is how it is therapeutic. Now, how do we pathologists interpret it? Okay. Now, the staining can be membranous. Now, why these staining patterns are different? Very simple. See, these antibodies are supposed to bind against specific antigens. And these antigens can be located in the membrane, they can be in the cytoplasm, and they can be in the nucleus. Okay. So, can you tell one antigen that will be in the nucleus out of any hormone receptor that we have discussed now? So, it is ER/PR. Okay. So, the hormone receptors are nuclear. There are numerous IHC. I just gave you one that has a very practical implication, or you can get a MCQ. ER and PR are nuclear. They are located in the nucleus. So the staining pattern will be in the nucleus. Whereas your keratin that is present in the cytoplasm, so you will have a staining in the cytoplasm. E-cadherin is an adherent molecule that helps in adjoining cells, so E-cadherin is present on the membrane. So if you see your HER2, EMA, E-cadherin, these are some markers that will have a membrane staining. You can have cytoplasmic stain. I told cytokeratin. Your keratin is situated in the cytoplasm, so you can have positive in the cytoplasm, and then you have nuclear staining. Okay, P63, P40, TTF1, all these are nuclear staining. Here you can see the nucleus is positive and the cytoplasm has not taken up the stain. Okay, so the principle is very simple. These antibodies go and bind to the antigen at different locations. The locations can be membranous, cytoplasm, or it can be nuclear. Now the workflow. When do and how do we use IHC? Clear? So first, most important thing what you have to remember is that we have a morphological diagnosis. First, if you talk about histopath, we have a H&E stain. When we are talking about cytology, we have a routine MGG, that is May, Grunwald, Jimsa or Papanicolaou stain. Whereas in peripheral blood, we can have a Leishman stain. Okay. First, we have to see whether it is normal, abnormal. If abnormal, what is the pathology? We have to suspect. Then we can try a test. Okay. Now, suppose, for example, I will tell you, if I see a Leishman stain, it is looking like a hemolytic anemia. Should I do a flow cytometry for leukemia? The answer is very clear. So I will not do, right? But if I look at a peripheral smear where a lot of atypical cells are there or atypical looking cells are there, I will doubt that there is a possibility of leukemia. In that case, it makes sense to go for flow cytometry. Similarly, when I see a biopsy, now the patient has a swelling, a biopsy is taken, it shows granuloma. Should I go for IHC? No, I will not go for IHC. I will go for a special stain. What special stain shall I do if there is a granuloma and necrosis? I shall do a ZN stain. Right. So if you have morphologically, first you have to see if there is a tumor and it is not categorizable, then I will go for these markers. If it is already categorizable or there is no, then no use of this marker. So first, morphological diagnosis is very important. Then comes the immunohistochemistry, and immunohistochemistry can be done on different tissues. I've already told you this is certain steps that we follow in immunohistochemistry. This is the workflow, how it goes. Okay, but you may get some MCQs like for the NEET students, they will say. So here, this antigen retrieval. Now what happens when we are first taking the tissue and putting into formalin for fixation? Okay, the tissue is put in formalin for fixation, for preservation, so that the proteins are not denatured. But during this fixation, what happens? The protein gets bonded with each other and these are not available, or these antigens are not available for the antibody. So before that, we have to do an antigen retrieval. And how this antigen retrieval? It is best done by heat method. Okay, two methods are there, heat method or enzyme method, but heat method is the preferred method for doing antigen retrieval. Okay, and in immunophenotyping, I told you that we do it through FCM or flow cytometer. That is principle is similar. Here we can see it. Immunohistochemistry we can see under the microscope, whereas immunophenotyping by flow we cannot see the event. We just capture that and see it on the screen. Okay, and after all this, even if the tumor is not categorizable, then we have to resort to molecular method. So can you repeat with me? First is morphological diagnosis. If there is difficulty, we will go immunohistochemistry or immunophenotyping. Okay, in cyto and histomaterial, we can do histochemistry, whereas in blood, we can do immunophenotyping. Even after that, if we are left with certain other information we need, or we are not able to categorize, some information is needed for further molecular treatment, then we can go for molecular methods. So that is the basic of what immunohistochemistry is all about. Now we will see what immunohistochemistry or how it is applied in various systems. So first is breast pathology. It is very important. That is why I kept it on the first priority. It is important for MBBS students as well as for the NEET students. Okay. Now, whether to differentiate primary versus secondary. Okay. In a breast tumor, suppose I have a tumor in the lymph node. I want to know whether this tumor has come from the breast or this tumor has come from some other place. So in that case, to know whether it is breast primary, there are many markers, but you must remember for an MCQ point of view, that is GATA3 is very specific for breast tissue. Okay, GATA3 is very specific. Then these myoepithelial markers like P63, calponin, these help us to differentiate invasive versus non-invasive. Now, invasive, non-invasive, you know, in situ. I mean to say in situ carcinoma and invasive carcinoma. In situ, it's surrounded by myoepithelial cells. Suppose I am having doubt whether this is in situ or invasive, I will do this marker, myoepithelial marker, that is P63 and calponin. If these markers are positive, surrounding the tumor cells, that means it is a in situ. Whereas if myoepithelial markers are missing, the tumor cells are going inside, then it becomes a invasive carcinoma. Similarly, to differentiate lobular versus ductal carcinoma, this again can come as a MCQ. Remember, whatever has been highlighted, you have to give in more importance for that because that can be a MCQ. Now, to differentiate lobular from ductal, E-cadherin is a marker. E-cadherin is lost in lobular carcinoma, whereas it is positive in ductal carcinoma. There are many spindle cell tumors. That is not that important point of view from preparation point of view or MBBS. You can just let it go. Now, I have spoken about prognostic markers. So, ER, PR, HER2/neu, P53, PDL1, or this is programmed death ligand 1. This is a new immunomarker. Okay. So, these are some of the prognostic marker. In addition to that, you can have a proliferation marker. Now, this proliferation marker is common for all tumors. Any tumor can have high Ki, so this Ki is also a prognostic marker. So these are some diagnostic markers in breast, whereas ER, PR, HER2/neu are prognostic markers. So if as an MBBS student you are asked in the exam which immunohistochemistry or which markers are done on breast tissue, you should confidently say ER, PR, HER2/neu, P53, PDL1 as well as Ki67. You must remember that breast carcinoma for therapy at present is classified based on this. That is luminal A, luminal B. See, I will not go into that, but I'm just telling you how important is it to apply this immunohistochemistry in order to categorize tumors. Then comes female genital. Now you know that breast is a very common tumor in India. It is one of the commonest. And before that comes carcinoma cervix. That is the most common in Indian female. So when we talk about female genital tract, we have to talk about the ovary as well as the uterus and cervix. So in ovary, we have certain markers like PAX8. Now PAX8 is a Mullerian marker. You must remember that PAX8 will be positive in female genital tract tumors and ovarian tumors. Okay. And CA125 and CK7. Now you know certain tumor markers. CA125 can come as a tumor marker question. CA125 is elevated in serum in which patient? It is serous carcinoma of ovary. Now because this protein is secreted by the tumor, so we can target this protein with an antibody that is anti-CA125. So that antibody will go and bind to this and that will be coming positive. So you understood the principle now. So these serous tumors will secrete CA125. They can also be positive for WT1. So WT1 and CA125 are associated with serous tumors. Okay. When we talk about mucinous tumors, now mucinous tumors can be primary or metastatic. The metastatic ones will be positive for 20 and CDX2, whereas the primary ovarian mucinous tumor will be negative for these two tumors. Okay. So here at least you must remember serous ovarian carcinoma. Now there is a second group that is sex cord stromal tumors. Okay, like say granulosa cell, they are the sex cord stromal cell, and if a tumor arises from granulosa cell, they will be positive for inhibin, calretinin, and FOXL2. So these markers you have to remember, they are very important from MCQ point of view. That sex cord stromal tumors are positive for inhibin, calretinin, and FOXL2. Now remember some of these markers, I will be repeating that at other sites also. Okay. Now, if ovary, we know ovary can also have germ cell tumors. I will come to the germ cell markers later. When we talk about uterus and cervix, so in cervix, what is the most common carcinoma? It is squamous cell carcinoma. So these two, P63 and P40, are squamous cell marker. You must remember that P63 and P40 are squamous cell marker. You may get MCQ. Remember, I am repeatedly stressing on this, okay? And there is something again, a P16. So P63, P40 are squamous, whereas P16 is, can somebody tell what is the marker P16 is used for? P16 is a surrogate marker for HPV testing. Now you must go and check your books. Why I am stressing on this, you will find from your Robbins or Hursman textbook, you will find the answer. Okay, why this P16? So you must remember P16 is a surrogate marker for HPV infection. Surrogate marker, okay, not a direct surrogate marker. If it is positive, we can say it is because of HPV. Now adenocarcinoma will not be positive for squamous marker, they will be positive for CK7 and Okay, cervix. If we have a doubt, then we will use this marker. But remember again, adenocarcinomas will also be P16 positive because adenocarcinoma and squamous cell carcinoma both happen because of HPV. Okay, even neuroendocrine tumors of cervix are positive for P16. So P16 is positive in squamous cell as well as adenocarcinoma of cervix, but there are other markers which will help them differentiate. In the uterus, you can have endometrial carcinomas as well as stromal carcinomas. So that is not a very important point of view, but if somebody wants to remember a marker for stromal tumor, that is CD10. Okay, so that was about the female genital tract. Now we move on to the male genital tract. Now in the male genital tract, the prostate carcinoma is common in the elderly. So and the markers that are used to diagnose prostate carcinoma are PSA. Prostate specific antigen is secreted by the prostate. Remember the principle, whichever protein is secreted, the antibodies are directed against that protein. So if there is a tumor that is coming from prostate, here it is secreting PSA, so it will be positive for PSA IHC. So IHC for PSA will be positive in that tumor. But if the tumor is not secreting PSA, even if we apply that marker will not come positive. So you must remember these three markers, not very important, just to show you, I have put it here. Okay. And in testis, we have again germ cell tumors are common. So these are some of the germ cell markers. I will talk about them later. So now coming to germ cell. Now you know germ cell tumors can happen in male genital tract as well as germ cell tumors can happen in the female genital tract. In the ovary, we can have germ cell tumors. We can have germ cell tumors in the testis. So first, we must confirm whether it is a germ cell tumor or not. Then we will go for categorization. I hope you people are knowing what are germ cells, because that's a very important question asked during your theory as well as during, you can get some MCQs on that, like which of the following is not a germ cell tumor. Okay, so germ cell tumor includes many subcategories. Again, that's a broader category. Okay, so to confirm whether it is a germ cell tumor or no, we do these two markers. Okay, SAL4 and OCT3Y4. You have to remember these are broader markers. They will tell you whether it is a germ cell or not a germ cell. Okay, then there are specific markers. First, these markers have to come positive. Then you can use specific marker like PLAP, placental alkaline phosphatase, that is positive in seminoma. You have AFP, alpha fetoprotein, that is positive in yolk sac tumor. Can you tell me some other tumor where alpha fetoprotein is positive? Try to recall one big viscera that is around 1 to 1.5 kilos in us. It is responsible for so much of metabolism. Have you guessed the answer? The answer is hepatocellular carcinoma. So I have told you that these tumor markers or these IHCs have multiple applications. Now you have to use it in a proper scenario. If it is a liver tumor, AFP is positive, it's a hepatocellular carcinoma. But if it is in the ovary and it is AFP positive, I will say that it is a yolk sac tumor. Then comes HCG, or human chorionic gonadotrophin, which comes from which cell? Human chorionic gonadotrophin comes from which cell? Can you name? It is cyto or syncytio, which one? So it is syncytio trophoblast. Okay, so choriocarcinoma is a tumor of a trophoblastic tumor where HCG can be positive, and then you have CD30, which is positive for embryonal carcinoma. So this germ cell category is little important for you because you frequently get some MCQs relating to germ cell, and as a NEET preparation, you should be able to answer SAL4 and OCT3Y4 are general, whereas the others are specific like AFP, HCG, they are specific for yolk sac or choriocarcinoma. Now other tumors that are very common is kidney. Now we are talking about genital, so we'll talk about the uro part also. So in kidney, certain tumors, like first of all, it will help you to confirm the tumor. I have told that there is a tumor. Then, you know, in tumor kidney, what tumor is most common? It is renal cell carcinoma, right? But again, you have to recall that renal cell carcinoma has different subtypes. Now, there can be a clear cell type, there can be a papillary type, there can be a chromophobe type. Okay, and we as pathologists can have a doubt, like say, I am saying this is clear cell. Now somebody may say, no, this is papillary. Another person may say, no, this is chromophobe. So to sort out that subjectivity, we can try certain markers and then we can immediately tell whether it belongs to a clear cell or it is a papillary. So what are the common markers? PAX8. Again, remember, I have told you that PAX8 is a Mullerian marker. It can be positive in ovarian tumors as well as it can be positive in kidney. It can also be positive in thyroid. So the markers have to be interpreted in the clinical context. I can't say that a tumor is positive for PAX8, so it is from ovary or it is from thyroid or it is from say kidney. I have to take it in proper context. Okay. Then you have CD10, CK7, like say your carbonic anhydrase. Now carbonic anhydrase is a marker which is positive in clear cell carcinoma, whereas carbonic anhydrase will be negative in case of papillary carcinoma. So I am not going into the detailed marker profile. That's not very important, but you can know that these are some of the tumor markers that are applicable in kidney tumors. Okay. Then there can be urinary bladder tumors. Again, if you remember, I have highlighted here GATA3. Now GATA3, I told you in one more system. Which system did I tell you? It is very important to decide it is primary or secondary. It is breast. Okay. So now you see GATA3 has an application in urinary bladder tumor. GATA3 has an application in carcinoma breast also. Okay. But here you have to be careful in which context you are interpreting. If I have an axillary node which is positive for GATA3, then I will think that this tumor is coming from breast or bladder. Which tumor, from which side it is coming from. If an axillary node has a tumor and it is positive for GATA3, it is most likely coming from bladder or breast. It is coming from breast, because axillary lymph nodes are very common to have metastasis from carcinoma breast. Okay, so that is how in proper context you have to use it. You can't just say this marker is positive or that marker is positive. So one message that I would like to tell you here is that a single marker can be positive in multiple tumors. You see P63, we have talked about squamous cell carcinoma, that is positive in urinary bladder also. So that is how it goes. Again, one more system that is very important and lot of markers or research is happening, that is lung tumors, and you will get a lot of MCQs or short notes in your MBBS exams. Okay, even this is a MCQ important point of view from your NEET exam. So what are the lung markers? Now here I have mentioned lung and pleura. First let's have a look at the lung. Now TTF1, thyroid transcription factor. If you remember thyroid, TTF, okay. So this is one marker which is present in thyroid also. This is one marker, the transcription factor, that is positive in case of lung tumors also. Okay, this is a nuclear marker. Again, remember I told you that one marker can be positive in multiple sites also. Okay, but napsin will be positive in lung adenocarcinoma. Okay, CK7, napsin, TTF1, these are markers for lung adenocarcinoma. And do you recall any tumor marker that is positive in squamous cell carcinoma? I have already told 2-3 markers during carcinoma cervix. So squamous cells are positive for, yes, can you recall? It is positive for P40, it is positive for P63, you can do a CK5/6. So P63, P40, at least these two markers you must remember from exam point of view. And do you remember P16? P16 is for HPV, okay, surrogate marker for HPV. So these are some markers that we use for adenocarcinoma of lung. And squamous cell, I told you P63 and P40. Now coming to mesothelial. Now pleura, if you talk about pleura, there is one important tumor, that is mesothelioma, right? So mesothelioma is one tumor that happens in the pleura, very common. And which are the markers? WT1, calretinine, CK5/6 and D240. Now you have to remember these markers from MCQ point of view, because in NEET very frequently asked is mesothelioma markers. Okay, even in your MBBS, if you have a short note on mesothelioma, you can write these markers. Again, do you recall WT1? When did I tell you? I told you that it can be positive in ovarian serous carcinoma. Do you recall calretinine? Which tumor in ovary? Which sex cord stromal tumor? Yes, it can be in granulosa and theca cell tumors. Okay, so you see again it has got multiple applications. When we talk about the gastrointestinal tumors, now gastrointestinal tumors can be epithelial, which arises from the lining epithelium. Okay, carcinomas arise from the epithelium. Whereas when we talk about mesenchymal tumors arise from the mesenchymal tissue or supporting tissue like muscle, nerve. So these are some of the tissues supporting blood vessels. Okay. So when we have a carcinoma and it is arising from the upper stomach and upper aorodigestive, it is CK7 positive. Okay. Whereas when we talk about tumor that is arising from the colon, that is arising from the rectum, they will be positive for CK20 and CDX2. Okay. CK20 and CDX2, if it is positive, we will think that the tumor is probably coming from the lower gut. Whereas if it is positive for CK20 and negative for this marker, we will think that the tumor is coming from upper gut. Okay, till now I hope I am very clear. Then we will talk about some mesenchymal tumors, right? Mesenchymal tumor that is common in this. Can you name some mesenchymal tumor? Now MBBS, this is covered as an important one. Mesenchymal tumor that happens in the stomach, that is very common. That is GIST, okay? Gastrointestinal stromal tumors. Now, if you talk about a GIST, which markers will be positive in GIST? I have already spoken about this CD117. Okay, now CD117 is a diagnostic as well as therapeutic marker. If 117 is positive in a spindle cell tumor, we will think that this is probably GIST, and if you try imatinib, that may be helpful. The DOG1 is a recent marker, or you can say relatively recent marker that helps to confirm. Certain tumors, if they are negative for CD117, they can still be positive for DOG1. And then still, if DOG1 is positive, we can say that it is a gastrointestinal stromal tumor. Now, these are some markers like SMA for muscle, S100 for nerve, beta-catenin for a fibroblastic tumor, like we can have desmoid tumors. Okay, so we will come to that later. Some tumors that are used in the hepato-biliary, in the liver, certain tumors are common, like HEPAR. The name is hepatocyte, it is HEPAR. You have alpha-fetoprotein. I told you there that alpha-fetoprotein is positive in hepatocellular carcinoma. But in addition to that, you must remember HEPAR, glypican-3, alpha-fetoprotein, arginase-1. These are some of the markers that help you to categorize and confirm hepatocellular tumors. Now, you know, liver is a common site for metastasis, right? GI, lot of drainage happens to the liver. So liver is a very common site of metastasis from gastrointestinal tumors. Now, suppose you get a biopsy where it is, you are not able to say on morphology whether it is a liver primary or it is a stomach. In that case, if I do a HEPAR, glypican, and they are positive, or your alpha-fetoprotein is positive, then we will say it is coming from liver. Whereas if your CK20 is positive, CDX2 is positive, then we will say CK7 is positive, then we will say it is coming from the gastrointestinal tract. And if a gastric tumor goes to the liver, what it is called as? So the MBBS students can answer what it is called as. If a gastric tumor goes to the liver, it is called as metastasis. Okay, so in metastatic tumors, some markers will be positive, whereas primary liver tumors, some markers will be positive. Then we move on to endocrine markers. Not very important for you, but you can just remember that TTF1 and thyroglobulin are for the follicular cells, whereas calcitonin is for the parafollicular cells. Can you name the tumor which arises from parafollicular cells? Okay, can you recall thyroglobulin and TTF will be positive in? I will give you the clue. Okay, papillary as well as follicular carcinoma, because they are arising from follicular cells. Whereas calcitonin is a marker, it is a serum marker, it's a tumor marker as well as on IHC. Okay, so calcitonin is marker for which tumor in the thyroid? Parafollicular cell. It is medullary carcinoma. Okay, so those were some tumors. Adrenal, cortical, and pheochromocytomas are not very important, but one question that you may get in MCQ is this S100. In pheochromocytoma, we have one type of supporting cell that is called as sustentacular cells. Okay, we have Zell-Bollen-like pattern and we have sustentacular cells. Now, these sustentacular cells will be positive for S100. Okay, so this is one of the features that you may get as a MCQ. Sustentacular cells in pheochromocytoma are positive for S100, or they are highlighted by S100. Now comes to another important, where we have maximum implication of immunohistochemistry is to subcategorize lymphomas. Now, whenever we see a light microscopy, a lymph node, big lymph node taken out, and we see it's, I may say it's a Burkitt's lymphoma, somebody will say it's a DLB cell, somebody will say it's a mantle cell, it's a follicular lymphoma, so many subtypes are there. So we face the challenge to exactly categorize it, because clinician will be after, sir, are you sure it is follicular lymphoma? Sir, are you sure it is mantle cell lymphoma? So that is the challenge we face. Now before that, we have to first confirm there is a lymphoma. Then we have to say whether it is a Hodgkin's versus non-Hodgkin's. Now, for MBBS students also, it is very important, as well as NEET goers. These markers are very, very important. You will get some questions relating to this. Okay. So in Hodgkin's, which are the three markers that is very commonly used? We take the help of CD30, the RS cells. Remember, RS cells, Reed-Sternberg cells. Okay. They will be positive for 30, 15 and PAX5. Now PAX5 is a B cell marker. Okay. So 30, 15, PAX5. These three markers will come positive in Hodgkin's lymphoma. Okay. PAX5, CD30 and 15, but there are some subtypes of Hodgkin's where you can also have 20 positivity. Okay, CD20 can be positive. Then you have EBV, LNP. Now EBV means Epstein-Barr virus, and LMP means latent membrane protein. Okay, so we know that certain Hodgkin's, some subtypes of Hodgkin's lymphoma can be positive for, or they are predisposed by EBV infection. So if EBV infection is there, it is more likely to be that subtype of Hodgkin's lymphoma. So we do EBV LMP. Now coming to hematolymphoid, now we know hemat and the lymphoid, so many. We have talked about Hodgkin's, but there can be B-cell lymphomas, there can be plasma cell disorders, there can be myeloid tumors, okay, myeloid leukemias. So many type of tumors, histiocytic tumors. So we will need some specific markers for them. Okay, again, when we have a lymphoma, we have to NHL, we have to categorize whether it is a B-cell lymphoma or it is a T-cell lymphoma, because therapy is very different. Remember, stressing on it, categorization is very important from our perspective, because the clinician has to give a specific therapy. B cell different, T cell different. Okay, just bear with me few more minutes. This is a very important topic. So hematolymphoid. Okay, so what are the important B cell markers that you have to remember from like MBBS or NEET point of view? 79A, 19, 20, PAX5. Okay, these four at least you must remember, which are B cell markers, and if they are positive, we can say that the tumor is B cell tumor. Now, what are the T cell markers? See, these are all double digits, whereas T cell markers are all single digit, 3, 5, 7. So if you can remember, 3, 4, 5, 6 is not there, 7 and 8. Okay, these are some of the markers that are positive in T cell. So 3, 5 and 7 you have to remember odd and single digit, whereas 19, 79A and 20 all double digit. Okay, these are all B cell markers. Then you have precursor marker. This is again very important from MBBS as well as NEET. Precursor marker. Now we have certain type of blastic lymphomas. Okay, lymphoblastic lymphomas. Lymphoblastic will have very aggressive course. Okay, so these tumors will be positive for precursor like 34, TDT, 99. Now they can be positive in T. If these two are present, then we can say it's a precursor T. If 19 is positive along with 99 or TDT, we will say it is a precursor B marker. Now you understood, these markers are not specific for B or T. They can come in B, they can come in T. But these are certain markers that are specific for certain lineage. Again, remember one thing, I have tried to put it in a very simplified way. In real life, there is a lot of overlap. It is not as simple as I am putting it, but for simple understanding, I put it this way. Then you have myeloid tumors. Myeloid, you know, they will be secreting certain enzymes. And so you can have MPO, myeloperoxidase, CD13, CD33, 117. See, 117 is myeloid also. It was positive in GIST also. So again, multiple implications. Okay, you have to interpret it in the clinical context. So again, 34 means immature myeloid. Okay, 34 means immature myeloid. 34 with B cell marker means immature B cell. 34 with T cell marker immature means it is an immature T cell lymphoma. Then you can have plasma cells. Remember, again, there's a NEET question. Plasma cells are positive for 38 and 138. These two markers you will have to remember. Plasma cells are 38 and 138. Very similar. 38, 138. Okay, easy. And because plasma cells secrete immunoglobulins, they will be positive for kappa, lambda, and the heavy chain, light chain. Light chains are kappa and lambda, and the heavy chains, they can be positive. Okay, depending on which tumor or which clonality, the specific antibodies will be positive. Then these are certain markers for chronic lymphoproliferative. If you are interested, you can read a little bit. And there can be some histiocytic tumors that are arising from histiocytic. I would mention at least one here, that is Langerhans cell histiocytosis. Very frequently asked question that which IHC marker will be positive in Langerhans cell histiocytosis. It's a tumor seen in the pediatric population. It's common in the skin, okay, skin and lymph nodes. And you have Langerhans as well as S100. This Langerhans is CD1A, CD1A. Okay, CD1A is positive in your histiocytic disorder, that is Langerhans cell histiocytosis. Now coming to the last part of it, then comes soft tissue tumors. Now lymphomas are common, even soft tissue tumors are common, but not as common as lymphomas. So these are some broader markers. Okay, these are some markers that we use for soft tissue, but we will come to the table where each subtype of tumor, which marker will be positive. When we talk about smooth muscle, you have to remember smooth muscle means SMA, H-caldasmon. H-caldasmon is more specific, SMA is less specific. So if you are asked one smooth muscle marker, that is H-caldasmon. That is very specific for smooth muscle origin. Smooth muscle tumors are called as leiomyoma or leiomyosarcoma. Okay. Now skeletal muscle. Skeletal muscle, can you name the tumor which comes from the skeletal muscle? Either it is rhabdomyoma or it is rhabdomyosarcoma. sarcoma. Okay, so which markers will be positive? See, desmin is positive here, desmin is positive here. So they are non-specific. But if you talk about myogenin, MyoD1, myoglobin, at least these two, myogenin and MyoD1, you have to remember they are very specific for skeletal muscle or rhabdomyosarcoma. Blood vessel tumor. Can you name the tumor? The benign is hemangioma and the malignant is angiosarcomas. Okay, intermediate tumors are also there, but not very important. And what are the markers? CD31, CD34. Now see, CD34 in lymphoma is a precursor marker, whereas CD34 in vascular tumors is just to identify endothelial cells. Also FLI1. Okay, FLI1. Now, if it is neurogenic, if the tumor is arising from nerve and nerve sheath, they will be positive for S100 and SOX10. These two markers you have to remember. If it is Ewing sarcoma, very common. Again, you will get a short note as well as multiple MCQs related to Ewing sarcoma. Ewing sarcoma is a small round cell tumor seen in pediatric patients, right? In the second decade, most likely from that 8-10 years to 15-16 years. And it's a very common in bone as well as soft tissues. So which are the markers that is used here? NK CD99, NKX 2.2 and FLI1. See the implication. FLI1 can be positive in vascular, FLI1 can be Ewing sarcoma. Okay, so it is in the context that you have to use. You cannot just say the tumor is FLI1 positive. So if you tell me the tumor is FLI1 positive, I'll tell you it can be Ewing sarcoma, it is a vascular. Unless I see the context in which we are trying to interpret the state. Okay, so CD99, NKX 2.2 and FLI1, these are markers of Ewing's sarcoma. Then comes synovial sarcoma. Synovial sarcoma is another tumor that happens in young male. You may get a question, a couple of questions related to synovial sarcoma. Not that important, but TLE is one of the markers that is found. BCL2 can also be tried. Okay. And then there are some fibroblastic and histiocytic like desmoid tumor. I told you beta catenin is a marker for desmoid tumor. If you want, you can remember it, but not that very good. But these, whatever I have put in the table, your smooth muscle, skeletal muscle, vascular, neurogenic, and Ewing sarcoma, these are some commonly asked markers. Okay, you may come across them in MCQs. Now comes the second last slide, IHC in unknown primary. Unknown primary means, now suppose somebody has a tumor node. We have seen the node. And from the node, we try to know where it could have come from. Now, node is not a primary site for a carcinoma, right? Node will have lymphoma as primary, but node cannot have carcinoma as primary. Carcinoma is always metastasis, right? So once we have a tumor in the node, which we feel is a carcinoma, our primary job is to find out from where this tumor could have come. Okay, so there we will use certain markers depending on the clinical context. Now, if it is a female with axillary node, I will use GATA3 to see if it is coming from breast, right? If it is an elderly male chewing tobacco, having a growth in the oral cavity, and there is a node here in the submandibular, I will think that it is likely to be squamous cell carcinoma. I will use a P63. I will use a P40, right? Now, if somebody has a tumor in the liver, okay, tumor in the liver, I will first try to know whether it is a primary or metastasis, right? I have already given you example. Now, if it is a metastasis, from where it could have come? Because you remember, we have repeatedly been saying in the books of Harsmon, you will find that metastasis can happen from gut, from any side, from upper gut, from lower gut, from lungs. Anything can go to liver. So we have to do certain markers in the liver tissue to know, or in the biopsy to know whether this is primary or secondary first, and then do some markers to say from which site it is coming. If it is a metastasis, like we can do a CK7. If it is positive, we can think upper gut. If it is positive for CK20 and CDH2, we can think it is coming from colon. If it is positive for TTF1 and MAPSIN, we can think it is coming from the lung. Okay. So what we have not discussed is neuroendocrine tumors. So this is again, you get a lot of questions in MCQ. So the markers for any neuroendocrine tumor is synaptophysin and chromogranin. Okay, CD56 is also another sensitive marker, as well as INSM1. This is a off late, like you can say, more recent marker. So synapto, chromo, CD56 and INSM1, these are markers for neuroendocrine origin. Which is the commonest site of neuroendocrine tumor? Can you tell where neuroendocrine tumors are very common? Where the neuroendocrine cells are maximum located? In the lungs and in the gastrointestinal tract. So these are two sites where you commonly have neuroendocrine tumors. And of course, melanoma. The first slide I started with melanoma, so we will end it with melanoma. So melanA, MART1, HMB45, S100, these are some of the markers for melanoma. Melanoma is the greatest mimicker. You must remember that melanoma in morphology can look like a sarcoma, it can look like a lymphoma, it can look like a melanoma, it can look like any other tumor. Okay, so it is the greatest mimicker in histopathology and in anatomic pathology, and these are some of the markers. You have to remember MELANA or MAT1, HMA45 and S100. These are some of the markers that we use to diagnose melanoma. Sometimes we take a CK20 and CK20 and CK7 approach. I have already explained it. If CK7 is positive, 20 is negative, upper gut. If 20 is positive, CK7 is negative, it is taken as lower gut. So similar approach can be taken in other sites also. It's not very important. That is another approach that we commonly take in unknown primary. So now we will summarize what we have learned in this session. First, clinical history is very important to decide the panel. Okay. Now, like I said, if an axillary node has mets, first I will think it's a female patient. I will think breast. So I will go for a GATA3. Should I go there for a TTF1? No. Because TTF is thyroid. Thyroid will not drain into axillary node. So that is the importance of clinical context. Remember, clinical context. It's not that just the marker. Morphology is the mainstay. First importance is given to morphology. We must see how it looks like on morphology. Then we have to try to apply the markers. Okay, we cannot just go for the marker up and down. If it's looking at tuberculosis, why should I go for a marker? If, like I have given example, if it is hemolytic anemia, why should I do a flow cytometry? Okay, so immunophenotyping, IHC, these are done after we see that there is a tumor and we try to categorize them. IHC is always used as an adjunct. It is not the primary thing. It is used in support of the morphology. I have already highlighted this point that multiple tumors can be positive for the same marker. We have seen that scenario. So many tumors can have overlap of markers. Most important thing what we as pathologists must know, the sensitivity and specificity of each marker. Now, like I have mentioned here, no IHC marker is 100% sensitive or 100% specific. So as pathologists and as clinicians, people should be aware what is the sensitive. Now, if I say TTF is positive, what is the chance that even if TTF is negative, it can still be a lung carcinoma? I will give you an example. TTF is positive in about 80 to 85% cases of lung carcinoma. So every 100 cases of lung carcinoma, you do a TTF1 staining. 80, 85 may take up, another 15 may be negative, but they are actually lung carcinomas. Okay, so I have to do another marker like MAPSIN-A, CK7. I have to do those markers also in order to confirm that it is actually a lung carcinoma. So no IHC marker is 100% sensitive or specific. And that is why we have to use a panel of markers. Like I said, in lung carcinoma, if TTF is positive, I have to do a MAPSIN. If TTF and MAPSIN both are negative, then it is very unlikely to be a adenocarcinoma of lung. Okay, I hope you have enjoyed this session.